Cancer doesn't live in statistics, it actually lives in our homes and in our families. And here in Ireland, where 1 in 2 people will face a cancer diagnosis in their lifetime, it's a disease that leaves very few families untouched. My own father passed away just 6 weeks after his cancer diagnosis, and this had a significant impact on me, our family, and it's a story I know that has been played out in literally hundreds of thousands of families who've lost loved ones to cancer. The good news is that AI can change that. So across healthcare, machine learning is quietly revolutionising how we treat and how we detect disease. Nowhere is this more urgent than in Ireland, which has Europe's second highest cancer incidence rate. So today I have the honour to speak with Doyin Badamosi, a physicist and AI innovator whose work epitomises this shift. His company, Durotemi AI Technologies, embeds cancer screening algorithms into your routine GP visit, and it spots cancer risks before the symptoms arise. He has another business called Radmol AI Systems, which tackles one of oncology's hidden crises, which is radiology errors, and up to 30% of them can actually delay very critical diagnoses. So, Doyin, I'm absolutely thrilled that you have found the time to talk to us. Thank you so much for joining me. And could we begin maybe by talking a little bit about what the cancer detection AI that you've created does?
Yeah, and I think, and that's addressing what we do. But I also, prior to that, I like to preface that with exactly why we do that.
Of course, thank you. Yeah.
Yeah, and also for whom. And I'll start with exactly for whom and why we do that. Physicians have an enviable task of being responsible for caring for patients. You have patients who will then trust their well-being to a physician's opinion or perspective of their health. This is a huge responsibility because remember, physicians are the mom, dads, brothers, sisters, friends. They live in our society. They have political views, they have emotions, they have opinions. They're also belabored by the same things that belabor every single one of us. And at the same time, they have to carry the mantle, the responsibility of making sense of our health. And in some cases, the room for error can be fatal. And so that's a huge responsibility, especially if the patient in question is a friend or not, or if it's a child or not, or if it's a spouse or someone who's close to someone they know or love, as it were. So it hurts when a physician realizes that they had confused symptoms for lung cancer, for example. They have confused it with maybe respiratory infection or tuberculosis or COPD, which is chronic obstructive pulmonary disease. And then it turns out it's actually lung cancer. They feel gutted. They have to deal with this. Needless to say, the patient would feel let down for a very long time, for as long as they live, if they live very far. And same can be said about colorectal cancer. So, in the real sense, you've got patients here who are vulnerable, and you've got physicians who have to care for them, who by their profession, the degree for errors, it's not the same. So these are the people, the patients and the carers, the physicians as well. Now, if we flip that over, of course, you can scale that and extrapolate that to be employers and the nation at large, because loss of valuable manpower would impact the society as a whole and economics as a whole. But then let's flip to why this is important. Now, the reason this is crucially important is because you do have cancer types with symptoms that overlap with common diseases. This makes early detection very challenging. Like I mentioned, you could, for example, have overlapping symptoms for colorectal cancer, where you say abdominal pain or bloated, which is similar to the IBS, which is irritable bowel syndrome, or changes in bowel habits, for example, including constipation or diarrhea. Now, commonly misdiagnosed as hemorrhoids, for example, or even gastrointestinal infection. And it turns out that that's actually not. It's actually colorectal cancer. So we could go on and speak the same thing about ovarian cancer or pancreatic cancer or gastric or stomach cancer. Now, the fact that you've got symptoms that can easily be confused as other types of diseases that overlaps between other types of diseases and cancer, it makes it even more challenging and makes early detection quite challenging. So that's why we do what we do. So now to your question about what it is that we do. We use artificial intelligence, machine learning, to identify risk of cancer when the symptoms are not apparent, which effectively would mean that we're able to take these benign symptoms and look beyond those seemingly benign symptoms. And we're able to call in multiple data points from patients' medical history, from patients' genomic data, as it were, or genetic data, as it were, for separate different biomarkers, as it were, to test results, investigation results, whether it's radiology or pathology reports. And we're able to make sense of that for as far back as possible and make an intelligent decision that helps the physician in real time.
And you do this through, isn't it that the AI is integrated with the patient's record system? So as I'm in my GP practice of the future and I'm telling my GP what's wrong, the GP is inputting my symptoms into the patient record system, and then the AI is like whirring away in the background, right?
That's right.
Wow, it's here and it's now.
Yeah.
That's amazing. So tell me about the evolution, like how is it being used, where is it being piloted, and how quickly is it going to be in every doctor's surgery all around the world?
Interesting, because you've got three core stages that you've got to go through. You have, so artificial intelligence allows us to be able to build models and implement those models into workflows in real time and globally. But the reality and the efficacy is that we need localized intelligence, which means having built a model out of Ireland here, we can't deploy that model in America, for example. We can't do that in India. We can't do that in China. We can't do that in Africa. Now, and the reason
because of ethnicity and the way our bodies are made differently, is it? Yeah.
Variables, otherwise you would have model that is skewed or biased, as it were. And during the COVID period, we had incidents of that in America, where we realized that some of the health equity, the disparity for health equity was there, but we never knew that. In terms of some, of course, we knew that generally, but in terms of understanding that there were equipments that were made that were more susceptible for certain groups as against others. And so we can't afford to make that mistake in this world of AI. We need to make sure that we integrate local intelligence. As a result of that, yes, we built other models here in Ireland, and we're looking to begin clinical trials here in a few weeks or months' time here in Ireland. But we're also doing the same thing in the US. We're partnering with Mayo Clinic in the US. And
that's fantastic.
That allows us to be able to optimize and fine-tune a model, leverage the ethnic diversity you have in America, and optimize or improve our models to be able to work with different groups of ethnicities, as it were. But also, we're partnered with two governments in Africa as well, where we're also fine-tuning the models within that specifically. And the reason for that is making sure that when we function as a global service provider, as it were, We're doing that with local intelligence, localized intelligence. Yes, global capabilities, but it has to be localized intelligence at play. So
Yes.
this year, next year is pretty busy where we're running across 3 continents and looking at validation trials and integration occurring in those 3 continents. Yeah.
Wow, that's fantastic. So yeah, so it's like it's back to this whole thing that everything is hyper personalized. So you're delivering a hyper personalized cancer detection model that's going to work across the world. I'm delighted to hear that you are also trialing into African countries because I fear that a lot of the AI or a lot of things being developed are being done for the markets where they have the most money to pay for it.
Yeah, and the reality is you can't take that away, because for any technology to thrive, you need resources for it to make it work, and so and it's the case you have with subspecialists. Why is that you have more of them in America? Because that's where the resources are. I mean, America's healthcare budget is over $4 trillion. And
Yeah.
so that's significant in that sense. But to the point you've made about Africa and the need for that, if you look at the trajectory or the evolution of cancer from where we sit today, cancer incidence is increasing globally. But
Is that down
mortality,
to diet? Oh, sorry to cut across. Is
diet,
that diet?
it's diet and lifestyle.
And lifestyle.
But mortality rate is reducing in the West, but increasing in the global South.
Yeah.
So,
Yeah.
and a lot of that, and I'll give you a stats that I'll give you some stats that is quite weird. Take pediatric cancer for example. Pediatric cancer in the West is, from World Health Organization, would say that 8 children out of every 10 diagnosed with cancer will survive. We would only record maybe 2 fatalities out of that. Flip that to global South, to Africa and South America and Asia, and, and the numbers work the other way around,
Oh
where
no.
barely 3 out of 10 will survive. 70% will not. And a lot of that has to do with early detection. Children have a much harder time telling you how they feel. It just,
Of course.
mommy
Yeah.
hurts.
I
That's
feel bad. Yeah.
I feel bad, exactly. Yeah, mommy hurts.
Oh
And
yeah.
that doesn't give the GP a lot to work with. Doesn't give the pediatrician a lot to work with. And so a, there's a compelling need to have artificial intelligence within the healthcare system to enable the physicians. I was reading a report about an East African country called Uganda and realized that there's one GP for every 25,000 patients. And that's
Wow.
insane. And the
Yeah.
report says that, well, if you had this GP go out and do their master's or further, the likelihood that they will come back to Uganda was significantly slim.
Yes.
So it means the gap, it's widening. The only way we can do that is to say, how do we enable the physicians on the ground with intelligence that enable them to be able to identify at-risk patients? Can we cater for every disease type? Maybe over time, but the reality is, like for Durotemi AI, we have prioritized at-risk disease, which is disease that does not do well over time, and that's cancer.
The big one. Yeah. I think you're going after the big one and I think it's very, very important work. Can we talk a little bit about the radiology AI that you've developed? Because I think that's really interesting in terms of people talk about, radiology is it's a profession. Wasn't it Jeffrey Hinton said that, it's going to be wiped out by AI. But what you've developed actually allows is the AI works alongside the radiologists. Do you want
Yeah,
to talk a little bit about that?
yeah, and what we're seeking to do, so we had started out generally just focused on optimizing or minimizing errors in radiology reporting. That was the initial initial
MVP, as it were.
as it were. That was
Yeah.
initial business case.
Yeah.
So, and the idea was to minimize the risk of errors in radiology reporting. And then we realized there's a subset of that where we have at-risk patients and cancer patients, hence where we are today. But there's an infusion that we've begun to work on right now. And what we're doing now is basically enable radiologists to be able to identify cancer patients very early, not just from the images,
From the data.
from a combination of data and the image at the same time.
Okay.
And so, but what we've done basically is we built out an initial model to do two things. One, can we effectively identify risk of error in a radiology report? And that's one element. So the model was trained to be able to identify where anomalies exist. And where anomalies exist, it will highlight that, and that allows the radiologist to be able to go back and revise that or choose to override it. And that option was there from an intelligent point of view. That's where we started from. And we realized that, yes, can we make a lot of impact? And yes, we deployed, and we had a clinical trial for that, and it was great. We were able to even minimize the risk of radiology reporting significantly. That said, we found two track that if we had a significant impact from radiology report, from diagnosis for patient A and patient B, but what made the difference for patient A and patient B was the type of disease in question.
Right.
And time becomes the factor. So while we identified the risk of error very early on in terms of radiology reporting, we wanted to do beyond that. Yes, it's great where physician can look at it and say, oh, the patient's got cancer. But that's great because it caught that. But did he really catch that early enough? That patient perhaps waited 3 months to have the report read. That patient perhaps waited 5 months before the examination took place.
And is that how Durotemi came about then?
That's how Durotemi came about.
Wow, that's excellent. Yes.
All the way back.
Yes, go back to the very beginning.
Yeah, that the first contact point with a physician.
Excellent.
We
That
could
makes so much
introduce a
sense.
technology that helps to triage and fast track that process.
That's amazing. That's fantastic. So how long has it taken you to go from the original embryonic inception of this through to today where you're piloting in the Mayo Clinic?
So when we decided that, when we realized that we had to do beyond just early identification of errors in radiology reporting, and we realized that at-risk patients, which are cancer patients, needed to be triaged much earlier on, we began to think about the possibility, because we didn't know it was possible to start with, right? And we started from a thesis, and the thesis was this: what does a GP do? How does a GP know when a patient has risk of cancer or not? That was the question. And the question was, a GP would look at symptoms presented in front of him, and those symptoms has to match a certain type of cancer. And based on that, it will seek further examination and further test to either nullify or validate that. So it means that the gatekeeper was the GP. And he was a gatekeeper, and the metrics or parameters he works with are the symptoms and his ability to analyze that. So can we train a machine to do the same thing, but do it much better? To look at thousands of data points with a GP, which a human can possibly not do. And so we began with that question. We pulled together a team of researchers, about 25 researchers globally. And we built an initial MVP around that. Mm-hmm. And we went a step further and thought we needed to narrow that down, working with data sets from the UK, and let's try that with lungs and colorectal cancer for starters. And we built another version of that, and now it's beginning to make a lot of sense. And so now we want to do a validation, starting clinical trials, and because the data sets we have used and the models have been built in Western Europe, which could be argued to be homogeneous data sets. So collaborating with Mayo Clinic, providing us access to 3 million patient data sets with significant diversity in terms of ethnicity.
Yes.
May not be the most outstanding variables in terms of diversity, but significantly more diverse than what we had to work with so far. So we're talking between then and now, 2023 till date was when we began intense research around this and build the first version, the second version, and where we are.
So that's in 2 years you've managed to create that. That's again, it's speaking to this whole thing about the pace of things in this AI space. It kind of brings me back though to your original point, which is about like GPs are humans. And as you were describing, the GP's role, I'm thinking about a GP who might be, say, a young parent who might be in work, they might be tired, they might have their mind on other things. There could be a really rare form of cancer presenting to them. And then now, thanks to what you've created, there's that kind of backup. So it's the AI working in tandem with them. It's another tool in their lexicon, I suppose. So I'm really, really delighted for you. I wish you the best of luck with the Mayo Clinic trial, and that you might roll it out across more ethnicities and more cancer types in very quick time, and continue doing the work that you're doing. And thanks from all the families.
Thank you very much, Mira. It's a privilege. Thank you. Appreciate it.
Thanks. Just one last question for anyone who wanted to contact you or even just send you some words of thanks. Where is the easiest way to find you, Doyin?
Well, it'll be via the website, or which is www.durotemi.com.
Yeah.
Or shoot me an email. You could, which would be db@durotemi.com.
Wow, you're very generous giving out your email address. Well, thank you so much. I'm really grateful for you finding the time. So go back now to saving lives and doing really great things with AI.
I appreciate it. Thank you very much.
Thank you.
All right, bye for now.
Bye.